So, Dr. Chopra, you had a talk on hypertension and its management in the CSI. So, may I ask you, how do you see how big is the burden in our country now?
I think hypertension is one of the major risk factor in India now. In different trials, or we have some trials from the south and north, which have shown that hypertension is almost 20% to 40% in our population, and the prevalence is very high. And the problem remains is that it is a triple paradox. It's easy to detect, but often remains undetected. It's easy to treat, but often remains untreated. And we have a potent drugs available, still the BP goal is not achieved. And basically, if we look at it, only 16% of patients are diagnosed and treated and achieve the goal, and remaining 30 to 40% in spite of treatment don't achieve the goal, and remaining 40% are undetected. So it's a big challenge for clinicians and all paramedical staff. How do we detect hypertension and treat it to a goal?
Right, Dr. Chopra. So, what about this white coat hypertension or masked hypertension? I mean, in your practice, what do you choose to detect the hypertension? Is it the home or the clinic BP?
See, basically, hypertension most of the times is detected in the clinics, but I think home measurement is also important, looking at the magnitude of the hypertension. And when we talk about the white coat hypertension or a mask hypertension, I think ambulatory blood pressure monitoring is going to play an important role, because around 5 to 10% of people have a white coat hypertension, 5 to 10% people have a mask hypertension. When patient is on hypertension treatment and he achieves the goal, still target organ damage continues, we need to look for mask hypertension, and for that home monitoring plays an important role. And ambulatory blood pressure monitoring gives an idea about the 24-hour blood pressure, night dipping is there or not, and the morning surge of the blood pressure is there or not. If 24-hour blood pressure monitoring correlates with a target organ damage, if patient is not having a night dipping, then the chances of complications are more. And morning surge is important because maximum strokes and infarct occurs in the morning, so that blood pressure control beyond the 24 hours is the key in a treatment of hypertension. And that's why ambulatory blood pressure monitoring, which is not very sparingly used, should be used in a routine practice for mild to moderate hypertension. When patient is on treatment but BP is not getting controlled, or in clinic BP is high, do ABPM, so it will give us an idea that BP is controlled or not. Or patient having a postural hypertension symptoms, that BP is getting down in the morning hours or the evening hours, that will be detected by the ABPM, and that's an important modality which we should increase in our practice.
So, Dr. Chopra, do you use regularly ABPM in your practice?
Yeah, I use it quite regularly. In patients of mild hypertension, it helps a lot, because it's a lifestyle modification or drug therapy is decided by the ABPM. Then the patients having the severe hypertension or patient having a target organ damage, really BP is controlled or not, or while in a severe hypertension he is already on 2 or 3 drugs, and we try to increase because white coat hypertension is there, so there also it helps a lot.
Right. And how do you maintain the target BP for your different group of patients? Like we have seen the JNC 7, JNC 8 guidelines, they keep on changing the numbers. And
see, basically a target BP, or what should be the goal of hypertension treatment, that's really changed after the JNC 8, or again European guidelines, Canadian guidelines, Chinese guidelines. They all are talking about 140/90. Previously we used to say lower the better, but the J curve still holds the true, because beyond certain limit, if you reduce the BP, then the patient can have problems of postural hypertension, elderly patients having giddiness. So 140/90 is the target nowadays, what different trials are shown. But in patients with diabetes or patients who are having a renal failure, and if there is a proteinuria, they say that the 130/80 should be the target. And after SPRINT trial came in, it's become really an issue, because that trial compared the tightest control of the blood pressure. In that arm, they reduced the blood pressure to average 122 millimeters of mercury, and the sparingly used, or where the 140/90 target was used, that trial is stopped prematurely, because they said that the BP control to a 122 millimeters of mercury, the benefits are much better, so that you control the blood pressure to 122 millimeters of mercury. But issue is how they measured the blood pressure in the SPRINT trial, because that was a closed room, no sounds, very dull lights, and the patient was at a very good atmosphere. which is not the true in our practice,
Right.
because
I
our
agree.
clinics are crowded.
Right.
There are a lot of patients, lot of hurrying, worrying is going on, and there we measure the BP. So I think 130/80 should be the target which we should be able to achieve, because they have used the digital meters in measuring the blood pressure, and here we are using the, still there are mercury manometers are used. I think we should all shift to a digital meters to measure the blood pressure, which will give an exact idea how much is the blood pressure in cases of mild hypertension.
Right. And how do you manage these patients? What is your first line and second line drug of choice?
Basically, if you look at the trial, JNC 6 said diuretics beta blocker, JNC 7 said diuretics, and now JNC 8 is talking about the diuretics again. But if you look at that, what should be the first line of treatment? I think the clinician who is comfortable with the different drugs, that can be diuretic, AC inhibitors, ARBs, calcium channel blocker or alpha blockers, can be any one of them, because all have shown the morbidity and mortality reduction and the benefit to the patients if we achieve the target or a goal of the treatment in that patient. Monotherapy, should it be really to start with one drug? But I think combination therapy, if you look at the ALHAT trial and then the different trials where the low dose combinations has been used, combination therapy is a preferred mode of starting a treatment in hypertensive patients, because if you look at the one drug, the reduction of systolic blood pressure is 6 millimeters of mercury. Two drugs, it's 11 to 12 millimeters, and three drugs, it's almost 15 to 16 millimeters of mercury. And half dose, standard dose of any drug, class of drug, reduces the blood pressure 80% to a target goal. And if you double it, it's only a 20% addition. So two drugs in a low dose, if we combine, the control of blood pressure is much better, side effects are less, and that's why combination therapy is preferable in starting the treatment for hypertension.
Dr. Chopra, I will ask the last question about the beta blocker. So slowly we see the beta blocker is going under the shadow for the treatment of
JNC
hypertension.
6 recommended the beta blockers as first line of treatment, and after that the beta blockers has not been seen in the guidelines.
Right.
They are saying that only patients having coronary artery disease, LV dysfunction, beta blockers should be used. But I think young patients where the sympathetic drive is more, the beta blockers should be used. Atenolol, they say that it's a culprit, because the atenolol doesn't reduce the stroke in the different trials which they have done. And basically they say that the central aortic blood pressure is not reduced with atenolol, and that's the reason the stroke reduction is not there. But newer beta blockers, vasodilatory beta blockers, that is nebivolol, bisoprolol, metoprolol, are a good drugs. They really control the blood pressure, peripheral and the central also. Only question is there is no head-on-head or there is not a large trial which have shown a benefits with these drugs. But I think in younger population, sympathetic overdrive is more. I'll prefer to use the beta blockers as a first line of therapy.
Thank you, Dr. Chopra. Thank you for your time.
Thank you. Thanks a lot.
How do you see how big is the burden in our country now?
I think hypertension is one of the major risk factor in India now. In different trials, or we have some trials